Welcome to another weekly case by Indian Masters through the Cardiovascular Therapeutics India. And we are privileged to have some of the best people in the field of coronary interventions from across the globe. We have got some of the best performers. And to begin the introductions, of course, we have the senior most person in our country, Dr. Samuel Matthew. So Dr. Matthew may be a grandfather, but I would still prefer, because he's so young and active, we would still call him the father of interventional cardiology in our country. It wouldn't be an understatement. And he has set up so many systems within the country, and the growth has been tremendous over this period of last 30 years. Then I welcome to Dr. Mama's Mamas. He's a very renowned person, visits India quite often. Last he was here in India live. That was probably the last live Congress, which in cardiology at least, that we have seen in our country. Soon after that, the COVID storm has taken it over. And Dr. Mamas is an expert in coronary interventions. Also, he is very good in the radial route for doing coronary interventions. And in addition to that, there are so many innumerable publications. So he's a prolific researcher and publisher. So you will find his articles all over and all over the cardiology spectrum. So warm welcome to Dr. Mamas. We have Dr. Khalid Al-Shebi. Khalid is at present based out of Jeddah in Saudi Arabia. And our history with Khalid, I was telling my friends, dates back to our days in University of Alabama at Birmingham when we were fellows with Gary Rubin. And Khalid has grown in stature with great leaps and bounds after that. And he's one of the senior most interventionists in the Kingdom of Saudi Arabia. And he's doing live transmissions into PCR. And he's very active in his publications, and his center is doing a lot of good work. So it's a real pleasure to have one of my old friends. And then Kirti Punamia is becoming a legend very rapidly in our country and globally, and with such clarity of thought and expression and such complex work which he has performed. So there would be very few words which I can really find to welcome him over here. So warm welcome to these experts. And then we have our presenter of the day, Dr. Praveer Agarwal, who's the director of interventional cardiology in my center along with us. And he has been a very prolific operator in a lot of complex coronary work. And Praveer is also a very close friend. We work in tandem, keep talking to each other during and between cases because we work on the same days. And so today, Praveer is going to show us some complex coronary calcified work which he's done. The first case, Praveer, once you introduce,
yes,
then we will take a break for discussion with our experts. And after which you will show us what you did. And while you are doing your presentation, wherever you feel that you need to engage a discussion with the experts, it is your call. You can also stop. Otherwise, once you finish this presentation, then I'll invite everybody to discuss. Over to you, Praveer. And you want to maximize, we can see your slides, we can hear you very clearly, and we are ready for your presentation.
Good afternoon, everybody. So it's
I'll request everybody else to mute themselves so that we can have minimum interference. That is one thing which is entirely in your hands. Thank you.
Good afternoon, everybody. So it's a privilege to be there in this meeting, and I'm sharing some of my, I would say, difficult cases for me. I'm sure that Kirti and Dr. Matthew are really expert in taking these kind of cases in and out. And first thing is very clear that Kirti is a master of imaging. So does Dr. Matthew. And imaging at our place is present. But what happens is when a routine list is there, I can't even think of imaging, because on a regular day before COVID, I'm about doing 15, 20 angiograms in a day, about 10 plasties in a day. So can't even think of taking any kind of imaging. I want to finish the work, and I do imaging rarely once I'm stuck. Nowadays, even if we want imaging, our iOS is not working. So partner with me. There are few places you will find that I need imaging, but imaging right now is not functional with us. This case, the first case I'm showing is done during COVID era. This is a 91 years old active male patient, and he's a working lawyer. Still, he's practicing, right? He presented to us with unstable angina for the last 15 days, and he's daily having morning rest angina for about 15-20 minutes with prompt relief in sorbitol. And his first angiography I did was in 2004 when he did the first like inferior wall MI, in which he had occluded OM2, and the ejection fraction at that time was also about 45-50%. So we left at that time because he did not have any symptoms. And at that time, the other disease was very, very minimal. So we left it. He had another angiography done in 2012 that showed similar kind of disease with some progress in the like LED and circ ostium, but not critical enough to be treated. So now it's 8 years past the last angiogram. His ejection fraction still is maintained about 45-50%. But when he arrived, his pulmonary pressure was 60 millimeters of mercury when the day he came in. Baseline creatinine level is about 2, and he's 91. So you can imagine the scenario. It's a bad scenario. He's 91, active, ejection fraction 45-50%, pulmonary artery pressure 60 millimeters of mercury, and baseline creatinine level of 2. And see, starting, aorta is tortuous. So we know that the support will be very, very minimal once we are operating. RCA is a small non-dominant artery, diseased, but doesn't matter. That's the left system. The huge chunks of calcium sitting like all over. Left main distal with ostiums of both LED and circumflex slightly stenosis. And you can see a small OMs included right here. This has been occluded since 2004, so we did not even bother about it. And since he's having rest angina and he can't even have a normal thing, so you can't leave him alone. So for first 2 days, we just decongested him so that the PA pressures are down to about, say, at least we can operate on him. So we give him some Lasix, and we were hoping that the creatinine will not go up once we are giving Lasix to him. But fortunately enough, the creatinine stayed the same. It was 1.9, 1.95, 2. And PA pressures came down towards 35-40 on the day we did his angioplasty. Now, this is the last shot. So now we can have discussion on the strategy of to plan this case.
Okay, so you have got a 91-year-old with borderline renal functions, 45% ejection fraction, densely calcified, dominant circumflex, left main bifurcation. All right, so this is good for starting a discussion. And we can start with Dr. Matthew. Dr. Matthew, if you're
yes,
sir.
Praveer, how is the circumflex ostium? It's also calcified?
Yeah, it's calcified, sir. Heavily calcified, sir.
Circ ostium also.
Yep.
No, if that is so, we need some debulking or some method to treat the calcium on both ostium of circumflex as well as LED.
Yeah.
Now, question is, which is the priority? Whether we are going to do both together and or only the tightest one being the LED, only that. These are the choices left for us. Unfortunately, we cannot make it into stage plasty because both the lesions are very close to the ostium. The stent in the LED has to start from the left main across the circumflex. Then it makes it difficult to handle the circumflex on a second sitting, especially with calcification. So first decision to make is we have to do both together. If so, which one first? To me, the last bar and the wire should be in the LED. To me, so least resistance you will have with the circumflex because that is not too tight. I'll probably take a 1.5 bar, get a rotor wire into the circumflex, rotoblade that, and probably upsize it because it appears to be about 3.5 vessel. So I'll step it up to 1.75 and then take everything out, wire the LED, and again start. Here I would step down. I will start with a 1.25 because that is very tight lesion. I don't want any slow flow in the LED with the circ also involved. The right is not worth looking at. So I'll take a 1.25, then step it up to 1.5. And if there is no slow flow, no problems at all, I may use the 1.75, which is already on the table. Just, it's a very short lesion, so I'm not worried about the slow flow or cut particles going and sludging the distal LAD. Once we do this, then the choice left to me would be using a cutting balloon, a 6 millimeter into 3.5 cutting balloon in the LAD, and if necessary in the circ also, or use IVL. Both are okay. If IVL finance is not a restriction, then probably I would use IVL 3.5, maybe 2 or 3 shocks in the LAD and followed by circumflex. So while doing the IVL, I will definitely have the wire in the circumflex. While rotablating the LAD, you cannot afford to have it. Then I don't think much issue is left for us to handle. Go ahead and stent whichever way you prefer, whether it is going to be the primary stent from circ to left main, and then LAD a tap, or either way, whichever way you want, you can do it. This would be the way I would look at it. And I don't anticipate any major constraints or complications during the procedure. I'll have a pacing wire handy because while doing the dominant circumflex, I may have some bradycardia. I don't like to give them too much of any atropine or anything, because tachycardia is not something I would like to have when I'm doing a rotablation. I'd keep the heart rate around 60, 70, or maybe up to 100, not more than that. I'm not very happy about doing that. So instead of giving atropine, I would prefer to have a pacing wire in, preferably elderly person, 91-year-old. I'll be very, very careful about the pacing wire. I will use only a balloon tipped wire. And these are the things I would think of.
Excellent points, sir. Dr. Mamas, what would be your take, and if you were to look at this case?
Okay, I mean, in all of these such cases, you have to think about the patient and the context of the patient. This is a 91-year-old elderly patient who's incredibly high bleeding risk. So in this sort of situation, I would want to keep it simple if I can, because doing a 2-stent approach would mandate 12 months dual antiplatelet therapy, and the bleeding risk in such a patient is not low. We're not doing this PCI for prognostic benefit, merely for symptom benefit. So the way I would deal with this in my unit would be 7 French radial. I would rotablate left main into LAD, probably with a 1.75 millimeter burr. I would then OCT to look at how big, number one, the ostium of the circumflex really is, and number 2, to look at whether we have fractured the calcium, because even after rotablation, sometimes you can still get concentric rings. If that hasn't fractured properly, I would then use lithotripsy in my unit. I would finally do a provisional approach, trying to keep to 1 stent, appreciating that the circumflex is diseased. But again, you have to think, what are we trying to achieve in a 91-year-old patient? And I think that if you can get away with a single stent approach, that's great. If you can't, then I would recross, predilate the circumflex ostium with a non-compliant balloon, and then use a lithotripsy balloon just to crack the calcium, and then probably finish off with a T-stent approach. But where possible, I would try to do this as a single stent provisional approach, given his age.
Great. Khalid, how about you? Are you there, Khalid? Okay, so we'll just find out whether he's got some connection problems. So Kirti, we are over to you for your suggestions on this. And would any one of you consider a hemodynamic support for this patient? When
Hello, can you hear me?
Yeah, Khalid,
Right.
there you are. So,
Yeah.
okay,
Hello.
and then we come to
Yeah,
Kiki.
heavily calcified distal left main Medina 111 lesion. I agree. If you do have imaging, I would like to start with that. That'll help me also size appropriately and minimize the amount of contrast I give to this gentleman with high serum creatinine. Unfortunately, I think you're going to have to you will end up with a two-stent strategy looking at the severe lesion in both the ostium of the circumflex and of the dominant circumflex and the LAD. If a lithotripsy balloon would cross, it would be a nice way to deal with this lesion because you'd never lose access to both branches. Where obviously with rotational atherectomy, you'll have to remove the wire from the vessel you're not doing the atherectomy on. So if lithotripsy would crosses, it'd be a very nice way to treat both ostia with lithotripsy. And then I would proceed with a two-stent strategy. Again, when dealing with these types of lesions where you really don't want to lose access to an important side branch, I think the DK crush technique of all the two-stent techniques, you never actually have to remove the wire before you've implanted the stent. So with the DK crush, you would have your wire both in the LAD and the circ. You can deploy the stent into the circumflex, crush it, you still have the wire in the LAD. With all other two-stent techniques, you're going to lose wire position in one of the two branches prior to stenting. So I would definitely use some form of plaque modification. If a lithotripsy balloon crosses, I think that would be my preferred method because that way I never lose access to both vessels. If not, I would go with rotational atherectomy successively, initially into the LAD and then into the circ. And I would consider an upfront two-stent strategy. And my preferred strategy would be a DK crush.
Excellent comments. And Kirti, I understand you have just finished a patient you did on hemodynamic support, right?
Yeah.
You did a impeller supported plasty today in the afternoon. So would you consider a hemodynamic support, and what would be your coronary strategy, debulking and imaging and stenting?
So there are two things. First of all, this 91-year-old has a pulmonary artery pressure which is raised. I'm not sure if he's got mitral regurg or not. I wasn't sure whether Praveer said he has.
Probably not.
No,
Probably not. So, but he has pulmonary artery pressures which are high. For me, a case like this starts with the left ventricular end diastolic pressure assessment. If the left ventricular end diastolic pressure is raised above 25, then my assessment tells me that this patient is very likely to get into pulmonary edema. As soon as he gets on, once we start boring, he'll drop his pressures and he might even go into pulmonary edema. So that is a big issue for me. Now, if there's hemodynamic support in my lab and if his peripheral vessels allow me to implant a impeller, that would be my first choice in that, like I did this morning. But there is a small issue where if the left ventricular end diastolic pressures are around 20 and not about 25, I definitely have a central access and I put them a small dose of dobutamine with NORAD because I don't want any hypotension. I want perfect control. So the preparation part has to be perfect for this. I have to use technology which would not need me to put any more contrast. And so OCT would not be, but IVUS, there is no question I would do an IVUS. My experience tells me that in these patients to put in an IVUS initially is almost impossible. You try to dig that catheter in and it won't go. And if it goes, it may not come back fully. And therefore, for me, IVUS or imaging is after rotational atherectomy. So rotational atherectomy is going to be the cornerstone of doing anything in this patient. Two, somehow I don't consider this two lesions. These are just one single lesion. It's a distal left main, ostial LAD and ostial circumflex for me is all left main. So it's a tri-artery complex of distal left main, ostial LAD, ostial circumflex. And I think Dr. Matthews put it very eloquently that the first artery is the most important artery that we need to rotablate. So I think if I were to go after, I would first typically, I don't use 1.25 burrs at all for these patients. I use a 1.5. I would start with a 1.5 into the LAD and then 1.75 in the LAD and then come back sacrifice my wire position, because that's what we've been doing. We've been doing it for the last 10 years. We've not lost a branch. And then come back and start with a 1.5 and a 1.75 in the circumflex. Once the debulking is done, I think that's when this is all. Once I go with the 175, I just put in an iris catheter into both houses over there, LED as well as the circumflex, and take a run back. The idea that I'm trying to pitch over here is one thing that one needs to understand over here is that this complex is very eccentric. Both these lesions are extremely eccentric, and therefore we just can't go with the sizes that can come by numbers of by Murray's law or something, because Murray's law might overestimate the size of the stents that we use in any of the branches, and therefore even in the left main. In these eccentric lesions, if the iris shows that there is a normal wall outside with very little atherosclerosis and most of the plaque is on the opposite side and that holds a lot of calcium, then of course there's the highest risk of perforations over there. So my strategy has to be stay safe after that. Will I need to use a cutting balloon, or would I need to use just an NC balloon, or would I need to go to an IVL? Much would depend upon what happens after the rotablator and imaging in my lab. For anything less than 180 degrees of calcium, you need a lot of, you may need an extra, you may need almost 60 or 70 pulses. For concentric lesions, they probably give in 30, 40. So you could use the same balloon to use to the IVL balloon for both the lesions. But I have a feeling that you'll end up using two separate balloons, and that balloon size for the IVL is important because IVL balloons can also cause rupture. The distal artery size of the reference of the LED is important. So if the LED is 3.0 and if the circumflex is 3.5, then I would have to choose a 3.0 IVL and use it for both. Use a 3.5 there, it's very likely to rupture. So that's what I would go based on those done, and you positioned yourself well with that. I think whether operator comfort in terms of selecting QLOT or DK crush would be, DK crush has so many steps, QLOT has probably a fewer steps. And it all depends on the comfort of the operator really. I would be happy to, it depends on what mood I am in that day, but for this angle, I think either or will work. The question is, where do you get the left main stent to? I think the ostium of the left main looks good over here, so I wouldn't pull my stent back to the left main ostium, but for me, the length of the left main is very important as well. This looks like a short left main for me. It means anything less than 10 millimeters for me is short. That means it's better to just pull the entire stent to the ostium, because when you start doing pots after the first stent, you pot it. You don't want to have a geographical miss with these high balloons at the ostium. So for me, this is always going to come back to the ostium, unless the ostium is more than 5.5 millimeters on iris. If the ostium is 5.5 millimeters of ostium, you don't need to come back. You just need to position yourself wherever your MLDs are around 5 or around that, so that you don't have to use very high balloons, because the higher the balloon you use in eccentric lesions, more likely you're going to rupture. That's what I would do, keep it simple. So impella, rotational atherectomy aggressively, 1.5, 1.75 in both the arteries. That will give me little room to have to play with any more lesion preparation. That will be almost a complete lesion preparation for me. But yes, if it on IBIS, if I need to do more, I will. And I would have a low threshold. If the vasculature is good, I would kind of look at a hemodynamic support given the pulmonary artery pressure and the left main, and it's a dominant left main for, and there's a non-dominant artery which is occluded on the other side. So this is a very complex problem, and anything that goes wrong is not forgiving. So yes to MCS if I can put it in, but if I can't put it in, I'd still have these patients with a low threshold to intubate them, and I would go by my LV and diastolic pressures. So that's my plan.
Yeah. Thank you, Kirti, for all the inputs. And after listening to all of you guys, I'm scared to show, right? So I thought a lot of, before I took this case up, as you know, the initial peer pressure was around 60. So I waited for 2 days after giving diuretics, and the peer pressure was down to about 35, 38. So that was the time that we knew that the LVTP has to be less than 20, right? So that's the time we took him up on day 3 of angiogram. We did not take him the same day, right? And initial plan, as you all guys are discussing, is some kind of debulking is required. So initial plan was, you see, LED lesion was very tight. We were very not sure that that anything would go without drilling it. But what was my plan was, supposing I drill it, supposing I lose the access of any branch, I may be in trouble because all the lesions are very calcified. The first step was, you see, the guiding is this catheter is hanging out because the tortuosity in the aorta. So I took a long sheet to just stabilize my guide there. So now it starts showing what I did. This is a XB7 French 4 millimeter, right? So this curve is 4 and still is sitting slightly outside, but I knew that as soon as I take my wire down, I can really pull the guide in. And the plan was to just see whether a balloon crosses there and make a room for my IVL catheter. Otherwise, all the plans were there to rotablate the LED and then see that how the things happen. I was missing my IVUS because IVUS is not functional at the moment, and nobody is going to rectify the IVUS in this COVID era. The Boston scientific has raised his hands that they will rectify once the things are normalized. But we don't have an option. We have to just fix this case because he was having unstable angina daily. For my luck, and whatever you say, both the wires are in, and this 2.5 into 12 millimeter balloon went in, and this I'm dilating at very high, about 25 atmospheres. This is giving up some space for my IVL catheter to go in. So both the wires are in, and now I'm going with the IVL catheter. And IVL did not have much problems in going there. It is a 4 into 12 IVL catheter into the LED first. And I give 4 pulses of shocks delivered to the LED. And it did make some difference. Like it was opening up at 4, and then we go to 6. It was opening it up. So once we gave 4 pulses in LED, then we decided to just take the balloon down to the circumflex. And again, we knew that it's going to take more took the same balloon down about 2.5 and 12 into the circumflex ostium. And again, the room was enough for the IVL catheter to go down. And there were 4 pulses of IVL in the circumflex ostium. And each time we were inflating the balloon, in the first pass only, the pressure dropped. Otherwise, he was maintaining a systolic pressure of about, say, 140 and a mean of more than about 80. So we were very happy with that. So pulses were very, very short. So we knew that he may sustain it. The fourth, when we were doing the LED IVL, when we did the 4th one, so he really dropped his pressures to nearly 100 systolic, but we came up as soon as we just took the balloon out. Now see, still, you can see this like this. You can see still the room is not enough for go at the stent, because still we need to get some more room for our stents to go in. So let me just go. Yeah, this is a 4 millimeter non-compliant balloon, ventralio at very high pressure, about 27 atmospheres, to break both the ostiums with the same balloon. It was appearing reasonable opening with the balloon. Now see, this is my first stent has come in the circumflex. I decided to just take the circumflex as side branch and LED into left main as the main branch. You seeing the stent is down, but see, this is not down on a BMW wire. Despite the short stent and a good support of the guide in the wire, opening up with the IVL and a 4 millimeter balloon, the stent is not going. So we knew that something is really, it might create trouble to us later on also. So we took an all-star wire down the circumflex. So on that wire, the stent went in. And now we're keeping the 4 millimeter balloon in the LED to crush the stent, like when whatever the protruding struts are there into the left main once we do the stent of the circumflex. You can see there's a 4 into 12 millimeter stent deployed at reasonably high pressures, and maybe about 16 or 18 atmospheres, right? And then we did the kissing, as we do always when we are kissing the struts, like both the balloons are up, the circumflex at nominal pressures and LED is high pressures. Still, we decided that the circumflex ostium has not given way. So we took an open NC 4 into 10 to just open up more of ostium of circ, because this is what the final thing we can do for circumflex. Otherwise, later on, it will not give us a chance. He was maintaining good pressures all along. There was not much drop in pressures. He was very stable. He was maintaining saturation 100%. And we were very, very happy with this progress. at this point, right. So again, we crushed it and we left the wire there because the left main is 5. So balloon will not be jailed once we put the stent across the circumflex stent. Now this is a 4018 stent into the left main to LED, right? And this is again deployed at nominal pressures and then pull it slightly back and went to high pressures, maybe about 18 or 20 atmospheres. And it's a good deployment there, but still you can see the waist there of the LED ostium, which is not very well open. As I told you in the beginning that I did not have any support of the IVUS, so I can't really help it out. Whatever is happening to us. And once the LED stent is deployed, this left main stent is deployed, you can see in the next frame, the left main also looks hazy here. And I'll show you in this next frame, there's some distal dissection also there in the LED, which we can very well see it here, right? The left main is sitting here, but I do not have an IVUS, so I can't say that it is really there or not, but we can't take a chance there, right? So then again, what we did was we just took a 3.5 into 12 millimeter stent there to fix it up so that we should not leave any chances of any problems there, right? So this stent was deployed nicely and it's looking reasonable there. Now again, this is a 4010 NC open balloon at really about say good atmospheres, about say maybe what we went up to maybe 35 or 40 atmospheres to just spread it up, and it gave us a good opening. And in the meantime, what we did, we rewired the circumflex so that wire is now into the true lumen, and then the kissing with the 4O balloon and our NC balloon and both the branches to complete the job at the bifurcation. And we were seeing that some haze in the proximal part of left main, proximal stent into the left main. Again, we had have no choice but we can't leave it there because you see we don't have an IVUS. If it's dissected, you are gone. So it's a 4.5 into 8 millimeter stent there in the ostium of the left main. And as you said, it's a 5O or maybe more of left main. So we did the 5O balloon at about say maybe 25 atmospheres to just spread it up in the left main ostium. And we were lucky to survive, and the patient was fine and maintaining hemodynamics all through without any major problems. And that appears to be the end result, which is looking reasonable given the scenario. But I was missing the IVUS all through, but I did not have it, so I did not have any choice.
So you seem to have a ocular IVUS installed, so you were sizing all your arteries. There are some comments from our audience that the LED may have been a 3.5, but of course, you need to keep the left main in mind. So yeah. Excellent, you've come out with a very good result. Let's have our experts, Dr. Matthews, again in the same order. Any comments? How would you look at this?
It's a different way of thinking. I mean, without debulking, going in with an IVL balloon and proceeding the way you did. There's an excellent thought process. But there are a couple of things I'm very unhappy about using an IVL balloon and not getting adequate dilatation of the balloon. 4 mm still had a residual narrowing when you finished 4 pulses. I don't like it because I have had bitter experience with post-IVL using an OPNNC balloon or any balloon, a super high pressure, 35 or 30 or 40 millimeters of atmospheric pressure is a little dangerous because the vessel is very, very supple. You can produce perforations, various other issues. I'm probably little too scared. I have had one patient, we had huge aneurysm forming just after the deployment of the stent with a high pressure dilatation. So I would be very cautious about that. even if it is IVL balloon, if I don't get I tend to get a result like this if it is only IVL. If we had used debulking followed by an IVL balloon, you probably would have had a better result in the proximal LED, which leaves some residual narrowing now. I would prefer, I'll be extremely hesitant to start the case. You were forced to do it because of unstable angina without any of the imaging modality, because that is something I got so used to, especially in the left main situation. I'm a strong advocate of advising everybody, preferably everybody should use imaging modality in all left mains, because you cannot afford to have even the smallest mistake in a left main. But overall, in the given situation, you did extremely well. But an imaging modality would have given us little more information what to do, whether we are happy with it or not. It appears little underexpanded or some residual narrowing. Because that lesion was an eccentric lesion, it could happen in spite of whatever you do. But overall, you did well. That's what my comments would be.
That's what I'm saying. I'm lucky that after listening to all you guys, I thought I was very lucky on that day that I did not have any perforation despite doing such a high pressures.
Dr. Mamas, would you make a comment?
Yes. So first and foremost, congratulations. I mean, you know, this is a complex case, challenging anatomy. I think first and foremost, you don't have IVUS or OCT available. IVUS and OCT are crucial to such cases because first and foremost, it helps you understand the distribution of the calcium. IVL only works in concentric calcium, so napkin calcification. If you do not have napkin calcification, there is no point using IVL. The second point from this case, which is important, is, I mean, we've used a lot of IVL in my unit. 4 pulses is not enough. You know, 4 pulses will not crack the calcium. So usually in my experience, in my hands, when I've used IVL, I usually need 20, 30 pulses to crack the calcium adequately. And we can see from the residual issue of under expansion that we haven't cracked the calcium properly. I think, you know, overall, you know, great results considering the limitations that you're working at. I think that all left main, though, should be done with imaging. We've published a paper in the UK from the BSIS data set in over 10,000 left main cases that shows using IVUS or OCT reduces your risk of 1-year mortality by about 30%. So I think it's mandatory, but appreciate that in your lab, you didn't have IVUS or OCT because it had broken down. So there's nothing you can do. But I think imaging is useful in that it will tell you whether IVL will work. If it's concentric, it will work. If it's not, then use rotablation, which would be my preference here. Or if it's nodular calcium, laser may have been another option.
So what I understand, Praveer, you have used 4 sets of 10 pulses each, right?
Yes.
Okay, so you used 40 pulses. But then again, this is an issue we would like more comments on, that after you have done IVL and you still have a waste, then what next? Yes, Dr. Matthews.
Atul, can I ask?
Yes,
I need a little more clarification on your comment. The IVL balloon does not work in eccentric lesions. Can you clarify that issue? Is it absolutely mandatory that it should be used only in concentric lesions?
So the reason why you shouldn't use it in eccentric lesions is that the ultrasound energy preferentially goes through the non-calcific portion of the vessel. And so it doesn't really work that well if most of the energy is dissipating through the more normal aspect of the vessel. And so you won't get fracture. And so the guidelines from the manufacturers are use it when you have napkin calcification. If it's eccentric, then it's better to either use laser, which we use quite a bit in my unit, or in this sort of case, I would probably start with rotablation and then do as you suggested, reassess and then use the IVL. And we've done that.
Yeah, so can I request Khalid to put in his comments if he has experience with IVL, or, and then over to you, Kirti, after that.
Actually, I like the fact that you did use IVL, but the thing is, as everybody has pointed out, the IVL catheter was clearly underexpanded, and I would have done what Master suggested. I'd have gone with more pulses. I think the more pulses you deliver, the more likely you are to expand this lesion. And I would not have stented if I had an underexpanded lesion. I'd continue to try and get the initial expansion better, whether that was achieved with further pulses using an IVL catheter or using a high pressure balloon, as was pointed out by Dr. Matthew. But I certainly want to make sure that my lesion was adequately expanded before I started implanting stents. But I think it shows I think you showed the utility of IVL when you have a complex lesion like this and you don't want to lose access to a side branch. It's a very elegant way to do that. But yes, I agree with all the other panelists, and I think you did a good job. You got away with it. I think I would be very wary of deploying stents before I had got adequate balloon expansion. But I do like the approach that you used using IVL for the reasons I pointed out earlier. And I think you did the right thing by using a 2-stent strategy here. And I think the DK crush is a good stent technique for these left main lesions.
Kirti, your comments, and maybe if you could also comment on sizing of the IVL balloons, and also what do you do if you have a calcific nodule, and where are you stuck with IVL or rotablation?
Because we really, in our country, we don't have adequate technology to deal with those. The calcified nodule and the eccentric lesions, as long as your wire bias is on the calcified nodule or it's on the plaque, which is calcium laden, you're going to be okay. But if your wire is going to be biased on the normal side of the artery, away from the calcified nodule, then your rotablator is going to end up doing nothing. It'll just swim across and probably do no ablation, at least with the 1.5. And you may often have to go to 175 or 2.0 to even touch it and shave a little bit of it. We have had no luck. I mean, and we've given up. I mean, after the first 2 cases, I gave up on using IVL in the calcified nodule or in the realms of a less than 180-degree calcium with normal artery on the other side. It just doesn't work. And if it works, it takes and consumes probably 80 pulses, all of it in one shot, and then you have a little bit of room. The sizing for me is crucial. And in a concentric lesion, the size of an IVL balloon for me is based on the mean mean luminal diameter of the artery that I consider a good landing zone. So if I consider a spot as a landing zone for the stent, then I would take the MLD, the mean MLD, and if it is 3.5, then I'd take a 3.5 IVL balloon, because that is at least the diameter, or the MSA that I would want is 9.5 millimeters square in that area. Now, the problem is that with eccentric lesions, like you can put in what you want. You could put in a 4 or a 4.5 or a 3.5. You are only going to get a lumen that artery will allow you without rupturing it. And therefore, when I put in a 4.0, and if I think going home, oh, I put in a 4.0 stent, then often enough, if I were to do an IVUS on this, these lesions, you know, before we used aggressive rotablation, we had a 30% incidence of underexpansion or suboptimally expanded stents in whatever lesion, however good they looked angiographically, the IVUS never satisfied us. And after using a step-up approach with escalating rotablation to 1.75 over 2, as the situation may call, and then using flexomes or using now IVLs, we don't know when we've started using IVL this year, but last year when we looked at it, 15% of our lesions, however we do it, with the best of our ability. Iris-wise, it is still a suboptimal MSA. When I say suboptimal, that means it is less than, it is between 80 and 90% of the reference distal MLA that is a target. That means if it is a 3.5 stent, you want it to be 9.5 and you can't even get it to 8, and that's suboptimal. So here I think that's serious. Two, I'm not sure, I couldn't understand whether Praveer used a technique of a crush technique, because I saw that he had a stent in the circumflex. I'm not sure whether that was a balloon in the LAD left main, or was it a mini crush, or was it a DK crush? I don't know what the technique used.
It was a mini crush.
Yeah, so when I saw the mini crush, I saw that the stent marker and the circumflex was a little too distal compared to what I would have landed it. I would definitely want it in the lumen of the left main to crush it, because I think if I, and also we need to crush it with a defined balloon, because unless the crush is complete, that means if the crushing balloon from the left main to LAD is a diameter, which is going to be for the complete expansion of a stent in the in that area, is not going to be complete. And when the crush is not complete, you actually deform the proximal ends of the stent and you don't achieve a proper crush. They all crowd in one zone, making a lip. Shaolin Chen showed that beautifully. So those are my concerns. And so I am concerned about that ostium of the LAD because it's eccentric and it appears to be angiographically suboptimally expanded. I'm concerned at the distal, at the ostium of the circumflex, which is a nightmare for all of us because unexpanded and plaque protrusion over there. Circumflex ostium is the nastiest bit that almost always keeps coming back and haunting us. I'm a little concerned that the edge of the stent in the circumflex lays in a area which has got a plaque burden. I just don't know because of imaging whether that plaque burden is more than 50% plaque burden or not. Those are my concerns. But otherwise, I mean, Praveer, your intuitiveness could just neutralize everything I've said and probably still get a great long-term result on this 91-year-old.
Yeah, your concerns are always valid, like whatever you're saying. Only thing is that initial plan was to just do the drilling, because fortunately this balloon went in. Otherwise, I had all the plans to drill it first and then take the.
I'm just so wondering why Praveer did not did not use it here. I would have held your hands back.
I was all geared up to do that, but only the balloon went in, and then I will catch a pass. So I thought, let us just try this one this time, and let us see. It might make some sense. But I agree with you. Supposing I would have done the rotablation of the ostium.
Matthews has to.
But just to make the counter argument, and this happened to me just last month. Actually, I had a very large heavily calcified right coronary artery, in which I ended up using a 2mm burr, and even after a 2mm burr, the balloon would not fully expand, and ended up completing the case using a 4.0 lithotripsy balloon, 80 pulses, and I got excellent balloon expansion and deployed my stents. Okay. Sometimes it works the other way as well.
So I have a confession to make. So Praveer has, you're right, Kirti. It's very difficult to hold Praveer back from the rotablator. And for the whole world has been doing IVLs, and Praveer was very adamant, no IV, he doesn't believe in IVL. And this was probably Praveer's first IVL case. So he was probably too tempted to try it, and then probably he wanted to use the same balloon for both the sides. And this is how we are in this case. So,
but concentrated with these very lesions on calcified nodules, even with rotablation, you get differential ablation tending towards normal tissue. So there is nothing that is actually perfect for these highly calcified and very eccentric lesions or nodules. Even rotablation, you tend to get less ideal result. All the ablative technology we have, whether it's rotablation or lithotripsy, generally works much better when there's concentric calcium.
I have a question for the rest of them. I mean, I don't have orbital atherectomy, but I would think that it would be a reasonable thing to do, because it is going to be probably the best thing for a calcified nodule and a less than 180 plaque. I mean, would you guys comment on this if you've used it? Because we still don't have that technology in India.
we have orbital atherectomy, and what I forgot to mention was that patient initially had come to me from another hospital where they'd used orbital atherectomy. It had failed, and that's why I started off with a 2 millimeter burr in this vessel. So that patient actually had orbital atherectomy, inadequate balloon expansion, followed by rotablation with a 2 millimeter burr, inadequate balloon expansion, followed by lithotripsy. I think it was not the lithotripsy on its own, but I think the cumulative effect of all the ablative therapies that had finally cracked that lesion and allowed balloon expansion. So I've used all three modalities, but honestly, I feel that rotablation generally gives me a better result than orbital atherectomy.
And the orbital have more chance of, it has been described, more chance of bad dissection on the opposite side of the nodule or eccentric lesion, because it doesn't recognize the difference between a normal tissue and a calcified tissue, and it keep on abrasion the normal tissue, and it causes significant dissection on the normal area. So orbital is not the first choice.
And Dr. Matthew, in this case, if you see, the wire bias would have been towards the lower side, and rotablation might not have done a good job also in this case also. Right?
No, I thought wire bias would have been favorable to you.
No, it would have been maybe opposite to that.
Yeah, once you wire it deep inside and give a tug on the wire.
The rotor was there. I just, as the balloon went in, I just decided against it. Yeah. All plans to go with the rotor first and then do the IVL. But as the balloon went in there and it opened up and it gave the space for the IVL, I said, "Okay, let me try this IVL this time and see that whether I can just keep the wire in the circumflex and do the job."
Praveer, see, I wouldn't be ashamed of accepting one fact. Even after doing even 100 cases or 200 cases, 500 cases of a left main bifurcation, still you would be very tense doing a left main bifurcation with calcification. You don't know what. So whatever we do to avoid an rotablator if possible, and keeping both axes open is a very important thing to all of us. Yeah. So we would tend to do that. No, this is all discussions for people who are listening to us to think more constructively. They should still keep these options available to us and think very positively.
Yeah. And
for nodular calcium, what I find is really useful after you've rotablated, if it's not concentric, it's the big nodule and you haven't quite cracked the nodule, then I usually go to laser. So I start laser with saline, and then if that doesn't crack it on re-imaging, then I'll use
contrast.
With contrast, yes, mixed with contrast. And you know, I've never had a failure of that to crack after you've rotablated, to crack the nodule. I've had cases where I've tried lithotripsy, it doesn't work because it's nodular and you've got a ring of normal vessel around it. And so lithotripsy will be no use in such situations. So, you know, laser's a good option.
Would that be a 1.7 eccentric laser?
Sorry?
Would it be an eccentric fiber 1.7 that you would go for those nodules?
Yeah.
Okay. Sorry, Dr. Matthews, you were saying something.
No, we did not have much experience with laser, but we have two cases where we had used an eccentric laser in calcific lesions. We had a very, very satisfactory result, especially with the contrast injection.
This has been an excellent discussion. We have 5 more minutes as per our this thing. Praveer, did you have 2-3 slides more, or should we take closing comments from?
No, I can have another case, which is a very short one that I can share.
Only a few slides, and then maybe everybody can make one final comment on the whole.
Right.
All right. So
this the case 2 is a 52-year-old male with a long-standing diabetes, and he's been in effort angina for the last 2 years. So this is coronary angiography about a year back also when he visited me last time, but he did not agree. Now for the last 15 days, he has been unstable angina with multiple episodes of postprandial angina and angina during homebound activities. So he was coming because of the angina. Now this is the angiogram. It's a long-standing diabetic. RCA, proximal lesion, mid lesion with calcium, distally, maybe some kind of spontaneous dissection, and then another plaque before another lesion before the crux. Just a badly diseased RCA. It's a huge RCA with multiple ramifications distally. Circumflex, the large high OM is looking reasonable with a minor plaque. And see the LAD. LAD again is heavily calcified, tubular calcium and tubular long lesion about say from proximal mid segment. So obviously seeing this kind of scenario, diabetic status and small arteries, he was given the first option of bypass surgery. Right. So that he refused. So can we just have a discussion, short discussion, and then we can show something.
Let us see what you have done, and then we'll have a final comment.
Okay, fine.
Yeah.
So obviously he was suggested bypass surgery, which he refused. So as a plan B, I gave him an option of angioplasty in 2 settings, which he agreed. So decided to RCA first, it had little calcium and appeared simpler of the two. So my suspicion was wrong. So I started with a regular wire, and you see 1 wire, then 2 wires, but nothing is going. I ruptured 6 balloons in that area, right, ranging from 1.1 to 1.25, 1.5, nothing is going there. Right, I took about an hour and a half to just do that, and there was no room created by that. So again, I canceled the procedure. I said, look, he may think overnight and he may change the decision tomorrow morning for a bypass surgery to be done. It was not, nothing was going. So I tried everything on that day. Again, he said nothing if he's leaving the hospital in case we are pushing in for bypass surgery. So next day morning, I just straightway I took for a rotablation as expected. And see, in the rotablation, what was the problem was the guy was sitting very, very like unhealthy way, sitting outside. And you see the wire also, you can't take a good room there, good sitting of the wire distally of the rotablation, but still it is in place. And I started drilling, and you see it's a 1.25 burr. And as soon as I push the burr into the lesion, you see the wire is coming back. So it's telling you how stiff is the lesion, and the wire was not going distally. And every time you just touch it, he has severe angina, ST elevation, pressure drops to about say maybe about 80, 90 systolic from 150. And you are scared to touch that lesion. So it was about 8 minutes of drilling. Nothing was happening there. Every time he's dropping pressures, and it's a small speck there, which is not giving way. And you are scared to touch because he's dropping pressures, ST is going up, and he's screaming out of the like table. Every time you're scared to touch this lesion. So I decided, look, this is the last time I'm going to touch this bar. In case it goes, it's fine. Otherwise, I'm going to just give it up. But last time is always good. Last time is always good, and you see this time the burr goes through the lesion. So I did a couple of more passes to just drill the situation. But after that, they behaved like a good boy. Everything went easily, like my wire, my balloons, even an Oxford balloon is going like a butter there. And it's a cakewalk. It's a cakewalk, just 2 long stents because the whole artery is diseased. And it's a reasonable outcome in that kind of RCA, which was not giving way to any balloon. So you see, just to share this technology, see, once the IVL has come in, they're saying that this like rota has gone, but no, I would say still, in that case also I was missing rota once I did not achieve the proper opening by IVL, but still, I was too long enough to go ahead because to use a rota at that time. But in this case, see, the rota is small, but has created such a beautiful result in this kind of RCA. And often, whenever these kind of complex lesions are there, I don't do them together. So another month later, I just checked the RCA, and then just took the rota for the LAD, which was not a very complex job in any way. It was a 1.25 burr, and it's like a reasonable drilling and a long stent. Obviously, it was 2.5 long stent, and the 2.75 balloon. It's a very, very reasonable outcome in this kind of scenario. So with this case, I want to tell you that even a small calcium can really give you so much of trouble, and the rota is the only solution in these situations.
So we'll take, this is a beautiful case, so we'll take comments from our experts, one comment each. And before we take the comments, I just wanted to clarify to Dr. Mamas and Khalid that we get balloons from Oxford. So that's a terminology I don't know whether you're familiar with. So sometimes when you have to use a lot of balloons in people, we have ethylene oxide prepared balloons. They are well preserved and they're ready for use again in patients. So this is a comment on the right coronary artery. RCA, how would you approach it differently? Or
I agree with Praveer's final comment that rota has its own place and it is never going to be replaced with IVL or any of these devices. Second is, I would have, I saw Dr. Yadava's comment on the screen. I would have agreed with him that I would start with rotablator for the right, looking at the lesion straight away. You would not even try to get a balloon in because looking at the lesion, it needed that. My comment was that other than that, everything else you did absolutely correctly and well.
Excellent,
But
Dr. Mama.
I may use 1.25 very rarely. The number of usage of my 1.25 bar is less than maybe 10%. 60 to 70% would be 1.5. And I would have been more happy if we used a 1.5 for the LED and at least a second bar for the RCA with 1.5.
Dr. Mamas, your comment?
Great.
Sorry, sir, you can continue. Dr. Matthew, you wanted to say something.
No, great result he got. 1.25 also gave him a good result.
Excellent. Dr. Mamas.
So my fellows know me as not a very patient man. And so after trying to pass the first balloon, whether it be Oxford or New York, if that had failed, straight to rotablation, no messing around. Great case.
Great, thank you. And Khalid?
Yeah,
and then
I agree. Yeah. If a balloon isn't passing, you can forget about an IVL catheter passing. So I would have done exactly what you did, and I'd have gone with rotational atherectomy. And I tend to agree with Dr. Matthew. I rarely use a 1.25 burr. Usually my baseline's a 1.5, and then if I need to upsize to a 1.75. Those are the two burrs I use the most often. Rarely I use a 2.0 burr in very large vessels, but generally it's either a 1.5 or a 1.75 burr.
Excellent. And Kirti, your comment? Kirti, are you there or?
I was on mute. I've unmuted myself.
Yeah, please.
So two things that I would do different from that I've been doing different since last year is one, I do use 1. I don't use 1.25 because they're very nasty to be stuck or stalled because of the nature of the burn. That's a problem. And for the 6 that we've had the last 20 years, 5 have been 1.25. So that's one. The second part of the story is that to make it a little, I normally I have a low threshold to go up to 190 or even 200,000 revolutions per minute in either of the arteries to ablate it. But of the last 8 months or so, I come back and I drop my revolutions to 110 and then run it past that artery. And this is based on some seminal work done from the Japanese guys, Yamamoto, and they said that when you run at low speed, your final burst speeds, you end up gaining a little more MLD. So if I have to virtually translate that into what I'm going to do after the rotor, then probably I might have to do a little less after the rotor. And that's just one point that I thought I should make. And then probably if one of you can have any additional comment on that, that'd be great. But otherwise, I was very happy that you chose a rotor. Okay, Praveer, I mean, thankfully, the rotor regret is really not required anymore.
Yeah.
The more I see these kind of cases, I wonder what our friends, the cardiac surgeons, are doing these days. But of course, all of us are addressing these complex cases and with so much of calcium. This was not possible before the technology was available. Anybody wants to take a final comment after Kirti's?
Well, I think if this patient honestly had accepted surgery would probably in the long run been a better option for him. He is young. We're using relatively small sized, very long stents. So the issues of restenosis and repeat procedures certainly there. So had he accepted surgery, I think this would have been a good patient for surgery for those reasons.
So this has been an excellent discussion and two different kinds of approaches to calcified lesions. But before we sign out, and I have my friend Nishit Chandra, who's a Twitter expert, and he wants to speak 2 words on Dr. Mama's contribution on the cardio Twitter handle, right? Nishit, there you are.
So first of all, thank you, Dr. Mathur, and for allowing me to speak. And thanks, Praveer, for the wonderful discussion on calcified coronary arteries. Now, I take this opportunity to inform you all people that besides coronaries work and all, this is one thing, Twitter, the social media, which is now enthralling us. And in this COVID era, it is basically keeping us informed. And if I have to look for one person, I will look no further than Mamas Mamas. In fact, Mamas Mamas was the one person I followed him first and never regretted. He is the Twitter king, and I would rather request Dr. Mathur that he should request Mamas Mamas to have a talk. He has a wonderful talk on social media and interventional cardiology. He has even written a publication. So if Mamas can speak few words on this, the role of Twitter for interventional cardiologists.
Great. Dr. Mamas, you're there to take the bow?
Yes, well, thank you. That's very kind of you. And Dr. Chandra has been one of the leading people on social media from India. I mean, certainly, I think these days, you know, it's really important for education, building communities, and discussing brilliant cases like we do, to be on social media. So for all the junior participants listening, and perhaps some of the panel members as well, I think it's really important for an interventional cardiologist in the 21st century to be there.
So
thank you
very much, everybody. Today we had a wonderful discussion, and I'm carrying away with so much of more information and thinking process along with me. And it's important that this is a valuable time in the evening where you could have done a lot more other things. So really thanks to all of you who have taken out this time for us, for having this discussion. But believe me, this time which you have spent over here has gone a long way for everybody else who were attending. And we have recorded these sessions, and it's going to be available on social media very soon for more people to learn from the experts who have been here today. Thank you so much, everybody, and bye-bye. Good night.
All the best.
Thank you, Atul.
Bye-bye, Khalid, Dr.
Thank you,
Mamas,
all of you.
Kirti, bye-bye. Dr. Matthews, so nice of you.
Bye.
Thank you.
Hi, Atul. Thank you very much for the invitation.
Thank you, and we'll connect with you again.
Yes.
Bye-bye.